So today's topic is on field of vision and perimetry. What is a visual field? Tracquair described visual field as an island of vision surrounded by sea of darkness. It is that area which is perceived simultaneously by a fixating eye at a given point of time. For our visual field, it is restricted medially by the bridge of the nose, and superiorly by the orbital rim, and inferiorly by the maxilla. So we get a maximum field temporally, which is about 90 degree, followed by inferior field of 70, then nasally 60, and the least superiorly 50 degree. So this graphs shows the hill of vision. The highest sensitivity is at the point of fixation, which corresponds to the fovea, where there is maximum visual sensitivity. The extent of field of vision depends on the following things: the illumination, the size and color of the test object, the contrast of the test object versus the background, the state of adaptation of the eye. The colored objects give less stimuli than the white object of the same size, so we use white colored test targets more often. Because for example, for blue and yellow, the fields are 10 degree less than the white, and for green and red it is 20 degree, approximately 20 degree less than the white. Why do we have to do the visual field testing? What is the significance? To find out the extent of a person's visual field, to diagnose and detect any diseases, and to locate the possible lesion, possible neurological lesion, and to find out the progression of the disease. How is our retina different from our visual field? Our what we see superiorly is perceived by our inferior retina, and what we see inferiorly is perceived by the superior retina. Likewise, what we see temporally goes to the nasal retina, and what we see nasally goes to the temporal part of the retina. The optic disc actually in the retina, it is nasal to the fovea. So hence in our visual field, it will be seen as a blind spot on the temporal aspect of the visual field. So our visual field can be classified into central 30 degree and peripheral field. So these are some terms we should be knowing. What is an isopter? It is a threshold line joining points of equal retinal sensitivity on a visual field chart. What is a scotoma? Scotoma is a non-seeing area, the area which we cannot see. It can be classified as relative or absolute. Absolute scotoma means the scotoma persists for all sizes and colors of the test object. And while relative scotoma is the area which is blind to certain size or color of a test object. The scotoma can also be classified as positive scotoma or negative scotoma. Positive scotoma is one which the patient is aware of, while negative scotoma is one which the patient is not aware of, like our blind spot. What is the center of fixation? Center of fixation corresponds to our fovea centralis in the retina. What is the blind spot? It corresponds to the optic nerve head 15 degree temporal to the center point of fixation. What is perimetry? Perimetry is the techniques used to assess our visual field, or in simple words, visual field charting. It can be classified into kinetic and static. In kinetic perimetry, we have a moving test object. The stimulus moves from a non-seeing area to a seeing area. It measures the extent of visual field by plotting isopters, and the result depends upon the experience of the operator. And the examples are Goldman perimetry, confrontation, tangent screen test, and these tests are more efficient and flexible, used for both central and peripheral fields. The static perimetry measures the sensitivity of each retinal points. Here, this stimulus is stationary, but it increases or varies in illuminance. Mostly automatic, and very little role of the operator is involved in this technique. Examples are automated perimetry and Goldman perimetry. So the perimetry and its examples. Kinetic perimetry, it includes confrontation test, the Jerem's tangent screen test, and Lister's and Goldman's perimeter. In Lister's perimeter, we can assess only the peripheral field, but in Goldman's, we can assess both central and peripheral field. The static perimetry involves the automated perimeters like Humphrey's Visual Field Analyzer HFA and the newer perimeters. Also, the Goldman's perimeter is also static one. These are the pictures of what we discussed earlier. This is an Amsler's grid. This is for central 10-degree defects, mainly for papillomacular defect. This is the confrontation test. This is a kinetic type of perimetry. It is done under the assumption that the visual field of the examiner is normal. In this picture, the examiner tests the visual field of the patient's left eye. So the patient is asked to close the right eye. Simultaneously, the examiner also closes her left eye, and the patient is asked to look into the right eye of the examiner. We should always make sure that the patient is seated at the same eye level as the examiner, and then the examiner moves her fingers from the periphery towards inverse. The same procedure can be repeated for the other eye. These are the pictures of Goldman's perimeter and Lister's perimeter. These are some examples of automated perimetry. Humphrey's Visual Field Analyzer, what we call as HFA, and this is our automated perimeter. What we have in our glaucoma clinic, it is SWAP, short wavelength automated perimetry. So now we are going to discuss a little bit detail about Jerem's tangent screen test. It is otherwise known as campimetry or scotometry. The Jerem screen consists of a black felt screen measuring about 1 meter square or 2 meter square in size, supported on a framework. So the patient should be seated at a distance of 1 or 2 meter according to the size of the tangent screen. The screen has a white object for fixation in its center, around which there are marked concentric circles ranging from 5 degree to 30 degree. The patient fixes on it on the central dot of fixation with one eye occluded, and a white target is brought in from the periphery towards the center in various meridian. So we have shot a video on how to do a Jerem's tangent screen test. Before doing the procedure, explain to the patient in the patient's language on how to do the procedure, and make sure that the patient is seated at the correct distance. For 1 meter tangent screen, the patient has to be seated at 1 meter. For a 2 meter Jerem's tangent screen, the patient has to be seated at 2 meter. Always make sure that the patient's eye is at the correct level as that of the white dot or the central dot of fixation. So here I am going to test the patient's right field of vision. So I have asked the patient to close his left eye with his palm. Now he is asked to focus at the central dot of fixation. The test object used here is 20 mm white object. Ideally, the rod attached to the object should be black in color. The test object is brought from the non-seeing area, that is periphery, towards the center. The object has to be moved smoothly with a speed of 3 to 5 degrees per second. Now the examiner is trying to map his blind spot first. The blind spot is located 15 degree temporal to the central point of fixation. So at this point he is not able to see the test object. This corresponds to the blind spot, that is, which corresponds to the optic disc in the patient's retina. After mapping out the blind spot, the examiner continues to move the test object towards the center. Then she continues to test all the other meridia, similarly from the non-seeing area to the seeing area. Ideally, we have to test every 15 to 30 degree meridia. And after finishing the temporal side of the right visual field, the examiner moves or crosses over to the other side to examine the nasal field of vision for the same eye. This is to avoid any distractions from the rod attached to the test object. So now we have tested the right visual field of the patient. Similarly, we'll be doing the visual field testing for the left eye also. Now, how do we chart the Jerem's test? It is very important to make a note of the patient details and the date on which the test is done. This can be useful for identifying disease progression. Now, how do we draw the data we got from the Jerem's test? This is how we draw the fields. While drawing, we draw only 3 concentric circles corresponding to 10 degree, 20 degree and 30 degree. As we said earlier, the blind spot is located 15 degree temporal to the point of fixation. Now, how do we identify which field belongs to which eye? For example, imagine you are the patient and I am going to test your right eye. Your optic nerve head is located nasal to the fovea. So, your left eye is occluded, and while testing you will be getting a blind spot on the right side of your visual field, that is on the temporal side of your visual field. Similarly, for the left eye, you will get a blind spot on the left side of your visual field. So, by locating the blind spot, we can identify which visual field belongs to which eye. And how do we describe this test in words? If we have a normal test, we will tell both fields. There is normal central 30 degree vision with normal physiological blind spot when tested with, here I used a test object of diameter 20 mm and the patient was seated at a distance of 1 meter, that is 1000 millimeters. The numerator will be diameter of the test object and denominator will be distance at which the test or the patient is seated. So here I'll be telling both eye central 30 degree field of vision is normal with normal physiological blind spot when tested with 20 by 1000 mm white object. It is very important to state the color of the object as we mentioned earlier, because the colored object gives less stimuli than the white object of the same size. So what are the pros and cons of this test? The pros are it is a non-invasive, cost-effective, it is a simple test. And the disadvantages of the test are it is subjective, it depends on the patient's honesty, and there can be language and communication gaps between the examiner and the patient. Thank you.